All right. I just wanted to bring back up quickly the ribs. We had talked about all the vertebrae yesterday, the sternum, and the bones that made up the thoracic cage. The ribs we had discussed as far as their attachment points to the thoracic vertebrae. You saw how the heads fit into the facets on the vertebrae, and I just wanted to highlight that a little bit for you here. The thoracic vertebrae allow the heads to fit into, remember, the superior and inferior facets. They span two different thoracic vertebrae for the most part. And then the neck of the rib with the tubercle, that raised bumpy portion, articulates with the transverse process. So from the body of the rib, the first articulation point, the transverse process, the second articulation point, the ribs project all the way around and make the thoracic cage. Now, as they go all the way around, the ribs are a really important attachment point for muscles that we'll see today. But I also want to call your attention to this little groove that's hard to see on this graph, but it's on the inferior border of every rib. It's called the costal groove, and that groove, that recess, allows the vein, artery, and nerve, this triad structure, to travel the length of the rib. The intercostal vein, the intercostal artery, the intercostal nerve. And they come in a bundle of three, and there are many different intercostal arteries, intercostal veins, intercostal nerves. At the lower border of each rib, that triad runs within those costal grooves. So if I were to use the colors that I've been using so far, red for arteries, blue for veins, yellow for nerves, they would line up kind of like this from wherever they originate, running the length of the rib to the sternum at the front. And they would supply blood or drain blood to the muscles along the way and innervate muscles along the way as well. And that's going to be important as we get into our discussion of muscles today. The intercostal vein, artery, and nerve. They always come in that group of three. I've changed the progression through the slides on muscles a little bit. Essentially, what I want to answer with this section is, how do we stay standing? How do we stay upright? And how do we breathe? So I want to look at what muscles help us stay standing upright and what muscles help us breathe. And the muscles of breathing, I've added a few slides to the slides that you have on Moodle. There's a bit more detail. And I'm not going to discuss the abdominal muscles for right now. So there are abdominal slides in the notes on Moodle. I'm not going to discuss those right now. How do we stay standing and how do we breathe? These muscles, the muscles of the neck and back that move the vertebral column, are how we stay standing. And collectively, the important ones that we'll focus on are the erector spinae muscles, the muscles that keep the spine erect. The erector spinae muscles. You've heard about the erector spinae probably before, and maybe you thought of it as one muscle, but it's actually three. From lateral to medial, I like standing. I like standing. The three muscles that make up the erector spinae are iliocostalis, I, longissimus, and spinalis. And depending on where you are vertically, they have different suffixes. But the names of the muscles, the root of the muscles, are these three words. And if you only remember these three, that's fine. Iliocostalis, longissimus, and spinalis. So starting laterally, iliocostalis is those series of muscles that are highlighted in red. And there are three different names for them depending on where you are along the thorax. Iliocostalis lumborum, is in the lumbar region. Iliocostalis thoracis is in the thoracic region. And iliocostalis cervicis is in the cervical region. If you only remember one thing about this, remember iliocostalis. It's lateral, and it spans multiple ribs along the lateral posterior portion of the thoracic cage. So think about what contraction of these muscles would do, right? The elastic band pulling the 2 points together. These would try to stack ribs on top of each other and help to maintain an upright posture. If you're hunched forward, iliocostalis would help to extend the back and keep you vertical. Those aren't the only muscles, though, that do that. The other two muscles of the erector spinae do as well. Longissimus, so named because it is one of the longest muscles in the body. Highlighted in purple here, it's actually the muscle that's pulled off to the side on the right. And there's a piece that extends further that you can't really see. It's hidden by this more superficial muscle, but you can imagine it extending all the way from the lumbar region, inserting the entire way up to the cervical spine, just a bit more medial to iliocostalis. Very similar series of actions, right? It would pull the ribs above it back on top to help keep you standing and vertical. I like standing. Spinalis is in the middle. It's closest to the midline, and these are a lot smaller. The muscle fibers are generally a bit finer. They bridge a few spinous processes from inferior to superior vertebrae. Similar set of actions to help extend the back and keep you upright. I won't go into details on the actions, but just notice the order and imagine what the contraction would do bringing the 2 points together. Notice I'm also not telling you the specific origins and insertions yet. We will warm up to that when we get to more important or bigger muscles. But I do want to start highlighting innervation and blood supply. Mainly because we've seen innervation and blood supply before. Innervation of the erector spinae muscles, the deep muscles of the back, we've already touched on. We talked about the spinal cord. The spinal nerves immediately diverge or break apart. They bifurcate into anterior and posterior rami. Posterior rami are those nerves that innervate the deep muscles of the back, and that's all they do. So the erector spinae, being deep muscles of the back, are innervated by the posterior rami of the thoracic spinal nerves. This is asterisked here because I'm imagining that we're just looking at the muscles in the thoracic region. If we were in the lumbar region, they would be the posterior rami of the lumbar spinal nerves. If we were in the cervical region, the posterior rami of the cervical spinal nerves. And I pulled this figure back up. This was from the section on the spinal cord to remind you these are the posterior rami that immediately branch when they leave the intervertebral foramen, travel past the transverse process of the vertebra into the deep muscles of the back. And these are the spinalis muscles. So innervation for any of these muscles, whatever level you're at, easy. Posterior rami of the spinal nerves. Blood supply, also pretty easy. We just looked at this briefly when we talked about the ribs. The arteries that travel in that costal groove at every level of the vertebral column are the arteries that supply these muscles of the deep back. They supply other muscles of the thoracic cage as well. They're not a singular point of supply, but the muscles of the deep back that we're talking about here get their fresh arterial blood from the lumbar and intercostal arteries. Intercostal arteries are the ones that we just referenced on the rib slide, but what are lumbar arteries? I added a slide here to hopefully help explain the difference to you, and this is a more advanced picture that's not in the slides on Moodle, and I wanted to show you, even though we're going to talk about this in detail in semester 2, this is not a major focus of what we're talking about now. I just wanted to reveal the blood flow a little bit for you. You can see from the main arterial conduit in the body, whatever that is called, we don't know yet, all of these little offshoots traveling in the costal grooves are the intercostal arteries. Those travel all the way around the rib cage, supplying the muscles along the way. Some of the muscles are behind the slide, the erector spinae muscles. They're supplied by those arteries. Now, ribs are only in the thoracic portion of the torso. Those muscles don't just stop when the ribs stop, they keep going all the way down to the sacrum. And these little offshoots, in a very similar manner to the intercostal arteries above, are the lumbar arteries. There aren't ribs to run along at this level. There are no lumbar ribs, but there are branches of the arterial supply that deliver fresh blood to muscles of the erector spinae and other structures in that area. So I just wanted to show you where the blood came from. And hopefully it's not so confusing what I mean by intercostal arteries and lumbar arteries. There are a lot of different smaller muscles that we could talk about in this region. So far, the muscles that we've talked about are those that will extend the vertebral column. They're all linear. They don't cross over. They don't allow rotation. They allow the extension of the vertebral column and allowing a vertical, allowing us to stay vertical as we're standing. The muscles that do allow rotation, I want to briefly mention because we have a nice view into them here and we won't come back to it again when we're done. We don't only extend the back. We can laterally flex, we can extend the torso, and you can rotate. You can turn right and left. The muscles that allow rotation work intimately with the vertebral column to rotate the vertebrae in relation to each other. And we can see them on this same figure, only shown at the bottom, but they do extend the entire length of the vertebral column. Multifidus is a broad band of muscles. You can see that they're angled obliquely. From the attachment points laterally, they move towards the spinal processes of the vertebrae. I think if you were to shorten the points, shorten the connection points, what would happen? The largest control over rotation, conveniently enough, is achieved by the muscle rotatories. Rotatories spans from transverse processes on one vertebra to the spinous process of the vertebra above it. So every pair of vertebrae in the vertebral column has a small set of muscles that will allow rotation of the vertebrae superior in the pair. You can see these really small muscles. If you look closely, this thin thread is one of the rotatory muscles. And there's one on the right and the left-hand side. It's just not drawn in on the left-hand side here for clarity's sake to look at the other muscles and not overcomplicate things. So transverse processes of the lower vertebra in the pair to the spinous process of the superior vertebra in the pair. Again, drawing those two ends together would allow you to rotate the vertebral column. If you were to guess, what would you say innervated? What nerves innervated these muscles? These are also deep muscles of the back, if that's enough of a hint for you. Some rumbles, but nothing convincing. Also, posterior rami. Posterior rami of the spinal nerves innervate all of the deep muscles of the back. These are deep muscles. They're innervated also by posterior rami. Conveniently enough, they're also supplied by the lumbar and intercostal arteries. So once you understand whether the shape, the orientation, the size of these muscles is somewhat different, they're all located in a similar region. They are turned on or activated by the same nerves, and they're supplied with fresh arterial blood by the same arteries. Iliocostalis, longissimus, spinalis, multifidus, and rotatories all receive the same innervation of blood supply. All help us to maintain an upright vertical posture, allowing extension of the back and rotation in certain cases. Now that seems like a lot of detail. We introduced 5 new muscles, common innervation and common blood supply, and it seems like a lot of detail, but it's not. It's not a lot of detail. We haven't even gone into the specifics of the origin and insertion, what facets or surfaces of the vertebrae these arise from, where the tendons insert on other vertebrae or other structures. We don't have enough time to do that, and I'm going to leave that for now. We're only going to look at those specific examples when we talk about big, important, easily identifiable muscles. So muscles of the deep back that allow us to stay standing. That was goal 1 of this section. Goal 2 of this section is muscles that assist in breathing. Muscles of the thorax that assist in breathing. There are many other functions of the thorax, but these are 2 primary actions. Help us stay standing and help us breathe. And these muscles work slightly differently. Obviously, they have a different role, a different location, different job. Standing is relatively static. You're always making sure that you're holding your balance and you're not going to fall over, but the muscles stay relatively stable. They have tone, they're contracted. The muscles of breathing vary. They contract and relax. They pulsate. And this is so that we can move air into and out of the thorax, specifically into and out of the lungs. Pulmonary ventilation is a phenomenon that we'll discuss in a lot more physiological depth in semester 2. But since we are looking at the scaffolding now, the muscles and bones of the thoracic cage, I think it's important to understand the mechanics of breathing. Air only flows, that is, it only enters the body, and you can only breathe it out because of changes in pressure inside the thoracic cage. Changes in pressure. So the muscles of breathing that we're going to talk about don't move air. They create a difference in pressure. Air moves secondary to a difference in pressure. Or air moves passively if there is a difference in pressure, otherwise known as a pressure gradient. Physiology is gradients. So as I'm speaking and I'm coordinating my breaths in and out, every time I take a deep breath in, that simply means the pressure in my thorax is lower than the pressure outside. How did I do that? Well, we're going to find out. But the only reason air moves is that pressure inside the thorax is lower than pressure outside. Air moves from high to low pressure. Temperature moves from high to low temperature. Concentration, things move from high to low concentration. It's a pressure gradient. And then conversely, the only way that I'm allowed to exhale or breathe out is when I create higher pressure inside the thorax than outside. And the muscles of breathing that we're going to talk about create these situations only. That's all they do. They modify the pressure in the thorax. If it's lower than the environment, air moves in. If it's higher than the environment, air moves out. How do muscles affect air pressure? How do muscles affect air pressure? They do it in a rather ingenious way. They don't compress the air directly. Muscles don't affect air at all. Muscles affect the container. And the muscles of breathing affect the thoracic cage in such a way that they modify the pressure in the lungs. And whether air moves or not is partly dictated by what we call Boyle's law, which says that the volume of a gas is inversely proportional to its pressure. That is, you can compress and expand a gas in a closed system. So without spending too much time on the physics, you can see here this is a closed beaker. This is sealed with a piston, and we have a little gauge measuring pressure, but the air in this beaker can't escape. And if I push the piston down, the plunger down, I can compress that air. Notice if you count the same number of orange dots, I can compress the air. It occupies less space, and the pressure goes up. Now, translating this to a living system is a little bit different. It's not a one-to-one translation because our lungs aren't a closed system, right? If I move the plunger, I don't compress and expand the gas. Air moves in or out. So this is analogous to the lung if, let's say you broke the gauge off. There's a little opening here. If I press the piston down, air would escape through that opening. That's all the muscles of breathing are doing when you exhale. I'm compressing the cavity. Air pressure rises. Pressure's higher in here than it is outside. Air moves. So what muscles affect the container? And for that matter, what is the container? Let's look at this slide to figure out what the container is. The container, the compartment that contains the lungs, whose shape is modified to allow air to move in and out, is the thoracic cage. It's everything on the top half of this diagram, and I didn't highlight it because there's a lot going to go on here as I highlight the muscles. But it's everything surrounded by the ribs on the top half of this diagram. Not the abdomen, which is the lower half, the thoracic cage, which is the higher half. Changing the shape of this container is what allows us to change the pressure and therefore move air. So what muscles are in the general vicinity and or wrap around that container? One of these muscles makes the wall of the container. That muscle is the diaphragm. Diaphragm shown here is the roof of the abdomen, the floor of the thorax. It spreads left to right, lateral to medial, anterior to posterior. It's an entire surface with a few very specific openings, but otherwise it's the floor of the thoracic cage. Changing how this works will allow us to change the shape of that container. What else will allow us to change the shape of the container? Anything that moves the ribs will allow us to change the shape of this container. There are a number of muscles connected to the ribs. We are focusing on two, only two. The intercostals. The muscles that span between ribs, intercostals. Technically, there are 3 intercostals, but for our purposes, we're going to focus on 2, the external and the internal intercostals. You can see the external intercostals highlighted in purple. They are the most external, or the most superficial. The fibers run down towards the middle. Imagine putting your hands in your pockets and the orientation of your fingers. That's the direction of the fibers of the external intercostal muscles. These have a very specific purpose in inhalation. The complementary muscles, the internal intercostals, you can either think of, if you put your hands in your armpits, the direction of your fingers would show you what direction the fibers ran, or they are just at 90 degrees. They're perpendicular to the external intercostals. They sit just behind them, still attached between adjacent ribs. The external intercostals and internal intercostals are 2 layers of the same set of muscles, basically. They are in very close association. Now, how these affect the thoracic cage, we don't know yet. I'm pointing them out to you here before we discuss the mechanics or the physiology of breathing. Slight variation to our understanding of innervation and blood supply. These muscles span the entire length of the ribs, and they are innervated by the nerves that travel the length of the ribs. That van structure, the intercostal vein, artery, and nerve that runs in the costal groove the entire length of the rib, wouldn't you be surprised to know that those nerves, arteries and veins, supply the muscles that run the length of the ribs as well. The intercostal nerves innervate the intercostal muscles, that is, activate the intercostal muscles. And if you wanted to compare them to the erector spinae muscles, and looking at this picture from the spinal cord, they're not posterior rami, they're some of the anterior rami that branch off immediately as the spinal nerves leave. So the anterior rami running along the inside of the ribs as they circumvent the thoracic cage. Arterial supply, where does fresh blood come from? Intercostal arteries. So lots of detail, but really only one major set of players in this area. External intercostals elevate. And we're going to see that elevation of the ribs opens the thoracic cage and allows air to move in. External intercostals elevate during inhalation. E-I-E-I-O. cheesy, but you'll remember it. External intercostals elevate during inhalation. The internals do the opposite. There's no fun mnemonic for that. Just remember the internals do the opposite. The internals are active during exhalation. The external intercostals elevate during inhalation. O. It's difficult to wrap your mind around how this works. How would contraction of muscles between two ribs change the shape of the thoracic cage? You have this really nice figure in your diagrams or in your slides on Moodle that show you that contrast on one side on the left, inhalation, the muscles that are active during inhalation, to the muscles that are active during exhalation on the right. And on the left-hand side, when you take a deep breath in, really only two things happen. External intercostals elevate during inhalation. That's one. So the external intercostals are shown here, and the arrows point in the direction of movement. You can kind of think of this as if you have a bucket sitting on the ground with a handle that can swing up and down. Normally at rest, the handle's just sitting against the side of the bucket. And then as you lift the handle of the bucket, it swings out a little bit and up. That's what we're doing with the external intercostals. It's trying to pull the rib below it out and around the rib above it. Out and around. So it makes the thoracic cage wider. The second thing that happens is that the diaphragm, shown here, this simple U-shaped or upside down U, red line, the diaphragm contracts and lowers, it drops. Those two things together make the space in the thoracic cavity bigger. Making the space bigger, it's like pulling the plunger out, pressure drops, air moves in. And for inhalation, that's the story. That always happens. Every breath you take in, those things happen. They can happen more forcefully or somewhat less forcefully, depending on how quickly and sharply you need to breathe in. For exhalation, usually you sitting there at rest, you don't need to exhale very forcefully. Most of exhalation occurs passively. If you pick up the lower ribs, if you drop the diaphragm, if those are active processes, if you just turn off that activation, things will return to normal. And so at rest, exhalation is typically passive. The ribs fall, the diaphragm raises back up, and they don't need a lot of activation to do that. Both of those things will make the container smaller, pushing the plunger in, pressure rises, air leaves. But you know, you don't only breathe out passively, you can breathe out forcefully if you need to, and you will in some upper level labs. If you forcefully exhale, that's when we start to contract the internal intercostals. And the internal intercostals, when they contract, they try to pull the ribs back underneath, making the thoracic cage smaller. You'll notice those aren't the only muscles on this slide. There are other muscles on the right-hand side. A lot of the abdominal muscles can be forcefully contracted when you exhale, but we're going to limit our discussion to not include them right now. Unless you want more detail? No? We'll leave it for now? Thoracic muscles only? Okay. Internal intercostals contract to bring the ribs back underneath to compress the container. So I want to try and show you the difference between somewhat compressed and not compressed, the difference in the container size. So the muscles that we just talked about change the size of the container. Ribs are raised and moved outwards. Diaphragm is dropped during inhalation. That's blue. Ribs move back, in and underneath. Diaphragm raises up during exhalation. That's red. And so the overall shape doesn't change a lot, but it changes enough to affect the volume in the thoracic cavity. In the blue situation, you have a lot more room for all the things that are normally in that space. All of a sudden, they can get out, stretch their legs a bit. There's a lot more breathing room. Pressure's lower. Pressure's lower. Air moves in. In the red situation, when you exhale, all of a sudden the room gets smaller. They start to sweat. They're crowded. The organs are crowded amongst each other. The air molecules are crowded. Not a lot of room. Pressure goes up. Pressure goes up. Air moves out. So the intercostals we talked about, raising and swinging the ribs out, pulling the ribs back underneath. What's not immediately clear, and what I want to end with before we summarize, is how the diaphragm moves. When you contract the diaphragm, it lowers. When you relax the diaphragm, it raises. You will have this figure in your notes, but I've included this here. We've seen this diagram already. This was the first one where I highlighted the diaphragm when I had that red box up on it. And it's just to give you a different perspective. If we're looking, this is an inferior view looking up, the diaphragm looks flat. But it's not flat. And we can see that on the left-hand side. The diaphragm is flat at the top, but then it drops down as it, or to its origin points along the ribs, the xiphoid process, and the lumbar spine. But those aren't important. I'm not going to ask you about origin and insertion right now. What you're going to notice about the diaphragm that's really unique is that this is one of the only muscles that inserts on itself. The diaphragm originates around its border. So everything around this outer circumference is the origin of the diaphragm. And the specifics aren't important right now. It originates around the thorax. And it inserts on this white area. It inserts on itself. It converges towards the center. And this white area is called the central tendon. The central tendon. It's freely movable. There are organs underneath and there's lungs above, but the central tendon can move up and down. And when you contract the diaphragm, like any muscle, you bring its two endpoints closer together. It starts around this outer border, and notice that outer border is fairly low when you look on the left-hand side. And if you contract the muscle, the central tendon is drawn closer to those points of attachment. The central tendon is drawn down. When you contract the diaphragm, the central tendon is drawn down. The container gets bigger. There's more space in the thoracic cavity. More space means less pressure, and air moves in. the origins that I have listed here are an FYI only. I'm not going to ask you what the origins of the diaphragm are, okay? But just so that you know, it originates at the xiphoid process along the lower 6 ribs and the lumbar spine, the lumbar vertebrae. Let's quickly summarize this section because we've covered a lot. Do you remember when we talked about vertebrae? 26 individual vertebrae in 5 regions. That number assumes that we're counting the sacrum as one, right? Remember the sacrum, 5 vertebrae fused together? This number assumes that we're counting that as one and the coccyx as one. 26 vertebrae, 5 regions, easy to differentiate. Cervical have bifid spinous processes. Thoracic look like giraffes. Lumbar look like moose. Sacrum, very easy. It's a large triangular shaped bone. Coccyx is small. Between each pair of vertebrae, we have a very specialized disc made of fibrocartilage. It's flexible. It has a jelly-like center. There's hyaline cartilage surfaces top and bottom to allow it to stay associated with the vertebrae. And we can flex either side, front and back. We can rotate a little bit. The intervertebral discs allow some movement between vertebrae. Being on the midline, they are symphyses. They compress naturally throughout the day, and then they expand at night when you unload them. It's the combined small movements at each disc that allows us to laterally flex so far, or bend over at the waist and flex the spine as much as we do. From the vertebral column, the ribs attach at the thoracic vertebrae only. The head's at the body, the tuberosity at the transverse processes, and then they move out around the entire thoracic cage. They eventually connect to the sternum, not directly, but through cartilage. And depending if they directly connect through cartilage, determines whether they're true ribs or not. False ribs connect through the cartilage of other ribs. And we just spent a while talking about the muscles of breathing, so I'm not summarizing them here, but you'll remember at the start of class we introduced the erector spinae muscles, the muscles that keep the spine erect, and the muscles that allow rotation. They generally run the length of the spine. The large majority are innervated by the posterior rami of the spinal nerves and supplied with fresh blood by the intercostal arteries. Any of the muscles of rotation, any of the erector spinae, supplied and innervated by similar sources. So leave that up there for a minute or two. If you have questions, you're welcome to ask. No? Okay. Have a wonderful class. Study hard. Midterm 2 is in 3 days.